Thanks very much, Denny. I'm here to tell you about imaging biomarkers and the QUIC concept project, which is about the validation of imaging biomarkers for oncology drug development, which I co-lead with Denny Lecombe and Jan Liu here from EORTC. So just a brief refresher. As we all know, the reason most of us come into work every day is not to measure biomarkers, but to improve how patients feel, function and survive. And that also is what gets us our reimbursement and benefits patients. Pretty much everything else that we could measure in a patient that's not a clinical measure is a biomarker. And there's a number of definitions in the literature. I like the one about putative diagnostic or prognostic utility. Some weak words there. Almost any measurement you make is a biomarker. So in 19th century or 18th century terms, a clinical measure is a symptom and a biomarker is a sign plus quantitation. And the reason I've taken you over this basic material is from the imaging world, we see that those biomarkers live in three domains. There's one domain which I've called the ex vivo domain, one the in vivo domain, and there's also a third one, patient-reported outcomes, which I won't talk about. So we heard a lot yesterday afternoon about these ex vivo biomarkers. The idea here is you take something out of the patient, and inside that there is an analyte which you measure in a separate device in a separate lab, either from a biofluid, a solid tissue, maybe a circulating free DNA, circulating tumour cells. In the second domain, where I live, you take nothing out of the patient other than a signal. This is the domain of imaging. It's also the domain of electrophysiology and physiologic measurement. And the measurement is entirely dependent on the in vivo device, such as the scanner, interfaced to the patient. And then, of course, the third domain is what a patient tells you about their condition. So the advantages of imaging biomarkers are very strong indeed. We've heard a lot about tumour heterogeneity at this meeting. We measure from all lesions, all parts of all lesions and normal tissue as well, something that none of the ex vivo biomarkers can achieve. We can do regular follow-up. Some of our techniques involve no or minimal non-ionizing radiation. In oncology, most of our cancer centres have fairly high-end imaging. They have PET, they have MR, and by the time our project reads out, most or many will have combined PET-MR, enable us to measure MRI and PET simultaneously. They integrate, they provide a lot of pharmacodynamic biomarkers which integrate the upstream signalling processes into common pathways. But in this domain that I live in, the in vivo biomarkers, there are problems. In the biospecimen world, you're typically measuring an analyte. This is analytical biochemistry. In our world, there may not, even in principle, be a defined analyte. You can do all your standardization long after the patient has gone home in the biospecimen world. In our world, the standardization critically depends on what happens when your patient is in the scanner. We have different instruments in every hospital, and there's not a lot we can do about it. We can't spend €1 million plus in putting our favourite instrument into each hospital. Unlike the biospecimen world, the operators of our instruments are often entirely unfamiliar with quantitative imaging. It's not their day job, it's something they do occasionally, particularly when we have specialist and unusual protocols. And the device is not designed for quantitation. Most MRI scanners, CT scanners, are designed to make pictures, and actually quantitation is perhaps becomes more difficult as the picture quality goes up. And whereas there are very well established academic and regulatory roadmaps, which we heard a little bit about yesterday, to take biospecimen biomarkers forward, for the in vivo and imaging biomarkers, the academic and regulatory precedent is really quite patchy. So you might think we're wasting our time with imaging biomarkers. Well, that's not true. Actually, there are a lot of imaging biomarkers which we already know and love. Actually, the TNM status is largely an imaging biomarker. Tumour size is an imaging biomarker. It's been around at least since the 1950s. We've heard a lot about FDG. Not so much at this meeting about dynamic MRI and K-trans, but that's also been very useful in showing biological efficacy of anti-angiogenics. And there are a few imaging biomarkers related to radiopharmaceuticals, which are also companion diagnostics. Also in oncology, there are some very important imaging safety biomarkers of things like cardiac function and interstitial lung disease. And these are already highly familiar to the drug developer. We use them for diagnosis. We use them to prove efficacy and select dose in phase 1 and 2. We use them to show efficacy in phase 3. Even if you look at FDA labels, you will find many of these biomarkers on FDA labels as for personalized healthcare, and we also use them to monitor recurrence and toxicity. But it's a short list, and it doesn't cover very many of the hallmarks of cancer, and this is where our project comes in. We need imaging biomarkers to cover more of the 11 hallmarks of cancer, not just the Warburg effect and angiogenesis. And we want, and in particular, we want to focus on proliferation, apoptosis, all causes cell death, and the invasive phenotype. We want to understand enough about the biomarkers that we can use them in early phase drug development to make go, no-go decisions, to show that we've got our efficacy and to make the case for going into phase 3. And we want to be able to do them multi-center and know that we get the same result in every center, and we can rely on the data from every center. And we also want our imaging biomarkers to work in important anatomic locations. Many patients in phase 1s will have metastases in the lung and in the liver, which are difficult locations for imaging. Imaging scientists left to their own devices will play around in the brain or in sarcomas or cervix or prostate or other anatomic locations which don't move. We are not about providing biomarkers which have full regulatory approval, but of course the standardization provides a platform where we can subsequently achieve that. So biological validation and technical validation, these are two independent axes. At the bottom left-hand corner, you have something which is pretty useless. You have no idea what it means. That's the bottom axis. And also on the y-axis, you can only do it in Professor Wonderful's lab on Tuesday, on a full moon. On the top right, you can do it anywhere in the world, and you can understand completely what the biomarker means in terms of predicting the patient's outcome. So to give you a few examples, I would say TNM is fairly easy to measure across the world, and we've got a pretty good idea of what it means for a patient. A PSA is probably easier to measure, but we have much less idea of what it means. And dynamic MRI is quite difficult to measure, and in terms of what it predicts about a patient is also quite problematic. So what QUIC concept is doing is taking some biomarkers which we are already discovered and established, and moving them into the middle of this place so that we can use them in drug development. So this is the elevator speech. by the end of the project, we can incorporate these imaging biomarkers into phase 1 and phase 2 trials of investigational therapies, knowing they're technically valid, that a change in the biomarker truly represents the underlying pathology, and that we can work multi-center and get comparable results in each center. Some of those things would probably be pretty obvious if you're working with a biospecimen biomarker. I'd particularly like to focus on this. No change in imaging biomarker means no change in tumor pathology, because there is a really nasty pitfall in biomarker use. It's a false negative trap. So in drug development, when we dream up experiments, the idea that we have is that we'll use the biomarker to test the hypothesis. The biomarker is modulated by the drug. We move on, make the go decision, and send a paper off to JCO. Fantastic. Also, as good scientists, we know that if the biomarker is not modulated by the drug, that means our hypothesis is not supported, and we will abandon the drug development. However, nobody wants to kill their children. And there's a nasty short circuit there where you get a result, the biomarker is not modulated by the drug, and the drug developer doesn't believe the result. They don't believe the biomarker data. It's improperly validated. It was measured in the wrong way. It was underpowered, whatever. Now, of course, our accountants look at the short circuit and they say, at the top of that, I've got €1 million imaging biomarker, imaging trial. And the decision tree leads me to the same place, irrespective of whether I have a positive or a negative outcome. Therefore, I can see an easy way of saving €1 million. And that is precisely why we have so many wonderful imaging biomarkers in the literature and such a short list that we can use in practice. Our aim in QUIC concept is to increase the space, increase the number of imaging biomarkers where we don't fall down that short circuit, where we've got nowhere to hide if the results are negative. So you've already heard about IMI. I won't rehearse that again. We have a budget of 16 million. We have 8 pharma companies, an SME, and 14 academic and non-profit organisations, including ERTC. And we've been running for just over a year. We have both animal and human work across a variety of centres. And right in the middle of there, I've put ERTC because of the very important ERTC clinical trial network. So what biomarkers are we looking at? You might think that at least the top 2 of these, this is a pretty boring list. We're not setting out to discover new biomarkers. We're moving them into that useful space where we can make decisions with them. We've got one about proliferation, FLT PET, one about cell death, MRI ADC, a caspase tracer for apoptosis, and a couple of more exploratory biomarkers of invasion and metastasis. So ADC, for those who are not familiar with, this is an MRI biomarker, measures the diffusion of water in tissues. So the idea is that diffusion of water is slow in live cells because of the tortuous pathways. It's fast outside cells. When we kill cells, we increase the amount of extracellular stuff. So in very crude terms, ADC is a proxy for the amount of dead stuff in the tumour. And it's easily measured in MRI. There's no contrast agent, no tracer, and it can be measured as often as you like. And so there's an example from the bottom. This is actually an animal study. At the top, a sham-treated animal, and at the bottom, actually a radiotherapy-treated animal, and you can see the large increase in ADC where the radiotherapy has increased the amount of dead stuff in the middle of the tumour. FLT, we've already heard quite a bit about at this meeting. It's a thymidine analogue, not incorporated into DNA, a putative biomarker of proliferation, or at least S phase. So boring list. These biomarkers are already very widely used. In fact, I went on the clinicaltrials.gov and I found 2,000 patients in FLT trials and 6,000 patients in ADC trials. So why are we wasting our time on all this old stuff? And the reason is most of these studies are single centre. They tend to avoid the difficult locations, the lung and the liver. They may not be designed and powered so if you get a negative that you believe the negative. Many academic and pharma studies or investigator-initiated studies are really designed to get towards getting the positive and writing the paper, not getting the negative and killing the drug. So what's our roadmap? The technical validation. In our world, there's a lot of work to standardize across the multiple vendors. Remember, the vendors sell their machines in the way that car salesmen sell their cars, on the basis that they're all different. So standardization is not a popular activity. QA, QC, training. We need regulatory and ethical acceptability. We use phantoms. We have volunteers traveling around between scanners to ensure that we get the same data. We look at reproducibility, repeatability. We have some really interesting work to deal with motion artifact and to deal with background uptake of PET tracers in the liver. And heterogeneity in medical images is a grand challenge. We will not solve it in this project, but we do intend to use a principled approach. Biological validation, we have 14 clinical trials in our program, small trials supported by a much more extensive program of animal work to look at effect size, temporality, dose response, all of the usual things in the Bradford Hill criteria to understand the meaning of the biomarker, and in particular, what a change in the biomarker means in terms of a change in the underlying pathology. So my final slide, and I think this applies to all the three talks, is that IMI is an experiment. There's nothing like this, I think, anywhere else in the world. It may not work. It will only work if we make it work. Bringing together 8, 10, 12 pharma companies who are more used to competing with each other and keeping their data proprietary, together with academic centres who may well think in very different ways, may think more about the positives and the negatives, may have a very different way of thinking about translation, and getting them all to work towards a common goal to deliver the elevator pitch in 5 years, rather than to deliver a disparate variety of papers going out into infinity. This is a challenge. It's an experiment. It will only work if we make it work. Thank you very much.